Hello, and welcome to our Reimagining Long-Term Care webinar series. My name is Neil Dreimer. I work as the Director of the Health Innovation Program at Healthcare Excellence Canada. My pronouns are he and him, and I'm so pleased to be your host today. So I want to recognize that HEC honors the traditional territories upon which our staff and partners live, work, and play. We recognize that the standard of living that we enjoy today is the result of the stewardship and sacrifices of the original inhabitants of these territories. We must commit to not repeat past mistakes and to work towards more equitable and respectful relationships with First Nations, Inuit, and Métis. Acknowledging the territories and the original stewards of these lands is a fundamental responsibility of our organization and part of our ongoing commitment to work towards truth and reconciliation. And related to that, I want to personally acknowledge that I'm joining you from the HEC offices in Ottawa today, which is on the traditional, unceded, and unsurrendered territory of the Algonquin people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. And I definitely invite you to share who you are and where you're joining from in the chat box on the bottom of your screen. I also wanted to mention that we are pleased to offer French simultaneous interpretation for this webinar. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We also invite you to share your questions and comments at any point throughout the webinar in either of our official languages. And if you have a comment or question, please add it into the chat box, which again, you'll see at the bottom of your screen. And we'll definitely spend some time to address as many of your questions as we can during the question and answer session towards the latter portion of today's webinar. Also wanted to tell you that if you need support at any time during the webinar, you can connect to our tech support using the chat feature. This session is being recorded and will be available on our website in the next few days to review and to also share with those who may have missed it. So that's sort of the logistics of today's webinar, but the reason why you're all here, I know, is, and I'm really excited to welcome our speaker for today, Dr. Carol Estabrooks from Translating Research in Elder Care, or you may know it by the abbreviation TREC, T-R-E-C, and she'll be discussing mental health and well-being strategies for the long-term care workforce, which of course is very topical, probably now more than ever. Dr. Estabrooks is a health services researcher. She holds the Canada Research Chair in Knowledge Translation in the care of older adults in long-term care. She is also the scientific director for the Pan-Canadian Longitudinal Research Program, Translating Research in Elder Care, or TREC. Carol has been the recipient of several awards and distinctions. Amongst the many are the Order of Canada and the Betty Havens Prize for Knowledge Translation and Aging. She's also a fellow of the Royal Society of Canada, the Canadian Academy of Health Sciences, the American Academy of Nurses, and the Canadian Academy of Nurses. So she is an expert in her field. So we're super pleased to have Dr. Estabrooks with us. And just a reminder, please drop in any questions or comments you have into the chat box throughout the session. So Dr. Estabrooks, over to you. Oh, I think you're on mute, Dr. Estabrooks. Oh, there you go.
Start over. I've only been doing these Zooms and Teams for almost 4 years. I'll get it right. So thank you very much, Neil, and thank you to Health Care Excellence Canada and to everybody who's joined today. I'm on Treaty 6 land, which is the traditional land of multiple First Nations people and the Métis Nation. So welcome from Treaty 6. I'm going to talk today about mental health and I'm also going to talk a little bit when I start the work environment that we live in, that people work in long-term care. And then I'm going to present findings of a small intervention study we did in the middle of COVID in response to some of the things we were seeing in our data. So I can't control my slides, so I may have to take a Valium before this is over, but here we go. So I think it's a really important question. Whose job is mental health anyway? And it's not a simple answer to that. First of all, we all bring genetic and environmental and situational and predispositional factors that put us more or less at risk. That's what we bring to the work environment. For example, the rate of PTSD in the general population is about 9%. So we shouldn't think that fewer than 9% of our staff would have pre-existing PTSD. And in fact, given the conditions under which many healthcare workers work, it's probably higher. But in the long-term care setting, there were such profound deficits pre-pandemic that we had a major set of structural conditions that affected even more strongly than normal and continue to affect the mental health and well-being of staff at all levels. So what do I mean by structural conditions? One of the things I study, have been for years now, is the work environment, or we call it the organizational context. The kinds of things that we think are modifiable that create a positive work environment. If you're talking to Pat Armstrong at York, she will say, and it essentially is a nice tagline for what we're all trying to do in this area, is that the conditions of work are the conditions of care. You can't have a healthy workforce if you have an unhealthy work environment, and you can't have good care quality and quality of life for residents if both of those things are out of whack. Then on top of these pre-existing things, as you all know better than me, we had this severe pandemic, and it hit long-term care especially hard, harder than many places, in part because of the population there, but also in part because the deficit was so big when we started. Next slide. I'm going to show you 2 or 3 slides just about the work environment, some empirical evidence. So we've been studying this for years, and one of the things we measure is a general physical and mental health assessment using the SF8, which is from the SF12, which is from the SF36. So these are well-used, validated scales. In every wave of data and in every group we've looked at, we've found that, in this case, it's care aids, physical and mental health scores are better in positive work environments. That we call those the green homes. And they're not as good in less favorable environments. Next slide. We also find that things you might call performance indicators or care processes are generally better in green homes or more favorable work environments. So this is a slide about miscare. There's less miscare, generally speaking, in green or more favorable work environments. And that's really important as an indicator of what the staff are able to accomplish on any given shift, and it goes to quality of care. And then finally, on the next slide, I'm just cherry-picked a few things to illustrate that it's not just the staff, it's care processes, and it's also residents. We all know that proper and appropriate symptom management is a hallmark of good end-of-life care. These 2 slides, these 2 graphs show you residents in the last 12 months of life. So 4 is 12 months before death, and quarter 3 is 9 months before death, etc. The closer you get to end of life, the higher your symptoms tend to be. And many of the symptoms we looked at, these are just 2, are modifiable, absolutely modifiable, maybe not entirely, but largely. So they both progress to higher levels from 12 months out to death. But when we took the residents and divided them in the homes they were in, the residents in green homes, or homes where there was a more favorable work environment, had fewer symptoms. So what does that, I mean, to me as a researcher, what it means is here's a whole new area of interventions that we can look at. Instead of doing what we often do, which is educate people or write new policies, those are not unimportant. But we can also say, if we create more positive work environments, that in and of itself will help us with really critical quality of care indicators. Next slide. This is not about the work environment per se. This is about burnout. These scales are from the Maslach Burnout Inventory, the MBI. It is the one we use most often, almost all the time since 2007. Later, I'll show you another measure that we don't use as often. The burnout inventory has 3 scales. These 2, cynicism and emotional exhaustion, are the 2 that define burnout in the MBI. The other one is a positive scale about how meaningful your work is. So if that's low, that also contributes to the assessment of burnout. In care aides and nurses and allies and managers, everybody we've ever assessed, they have extraordinarily high levels of this positive job efficacy, the sense that their work is important and has meaning. That's probably somewhat of a buffer against these 2. And why am I saying that? Because if you look at this, there were really important changes. Wave 5 is a survey we did we finished it just weeks before nursing homes were closed and the pandemic was declared in super early 2020. We came out of the field in February of 2020. And so the bottom 3 bars on both of these graphs are pre-pandemic, wave 5. And the top 3 on both of these are during the pandemic. That was in late 2021. So you can see that the care aides haven't shifted a lot. They shifted a tiny bit, and the nurses didn't shift a whole lot. But in this particular slide, you see quite dramatic changes in the manager reports. Because this scale is stubbornly stable, it doesn't move much, which suggests that staff in long-term care homes have been living with pretty worrisome levels of burnout long before the pandemic hit. And for some reasons that we can talk about if there's time, the care aides and the nurses seem a bit more resilient to this particular measure. There are other things they're not doing as well on. But when it moved this much on the managers, it caused us a lot of concern. Then when we did interviews with managers, we found validation. And when we did webinars at the end of the study with managers, we found even more validation. I've not ever in my life done webinars. I said to the staff, why are the managers turning their cameras off all the time? Is something wrong? And I couldn't see them really well. And they said, no, Carol, they're crying. That's why they're turning the cameras off. And I think that was in part because what they were feeling was showing up in real data. And this is me extrapolating, and maybe somebody will listen finally. So our government here in Alberta is certainly listening, and there's a lot of activity to try and come up with ways to help all levels of staff, and especially the managers. Next slide. This is a slide, and I have to put about 5 caveats around this. This was done in late 2021, and it goes to an earlier comment I made. This is not a diagnostic tool. This is a screening tool. So people in the red zone answered enough questions positively that they would screen positive, and in a clinical setting would be referred for more mental health follow-up. Now, lots of people with pretty severe PTSD are very high functioning and walk about us and work among us all the time. So having a lot of symptoms doesn't mean you're not functional. It does probably mean you're suffering quite significantly, and it may be affecting your health. So the kinds of things this tool looks at are intrusive thoughts, nightmares, inability to sleep, going off with outbursts of anger, those sorts of things. About a third of all the members, all the staff we looked at in long-term care, screen positive. That is not inconsistent with the general literature during COVID in all healthcare settings. So to me, that suggests a workforce across the health industry in trouble. And in our case, in particular, in long-term care, really worrisome levels. We have other data I'm not going to report today because we're just writing it up on another measure we used in our breathing study, and I'll talk about that later, that suggests that it may be for some groups worse than we think. What you know is what you measure, and a measurement of different things is a choice that different people make. So we only know what we continue to measure and what we continue to talk to people about. For me, this is quite worrisome, but it's not a 911 call yet, because we're going out again. We're out in the field again. It'll be 2 years after this, trying to see if that trend stays the same. Does it worsen, which would be really alarming, or is it improving? Theoretically, you might assume that as the pandemic abates, sort of, that these scores will look better. Next slide. So that leads me to the last slide before the little study I want to talk about. There's a lot of talk now about trauma-informed care, trauma-informed frameworks, a trauma-informed approach. You'll see it all over the new National Long-Term Care Standards. There are two very big, they're not substandards within it that talk about the need and the requirement for a trauma-informed care framework. And it's layered all through almost every item that you look at in there. You can do a trauma-informed approach just like you can do any other thing that we try to implement. You can say a lot of nice words and put it in your mission statement and have it there for the accreditors to look at and whatever else that people do. That is not, nor isn't anything like person-centered care or quality of life. To really do trauma-informed care, you have to take it seriously, and you have to start at the top and work down. This is not just for the frontline staff. The commitment has to come probably from the provincial level and the regional levels, as well as organizations. Every home doesn't need to develop this. Organizations can develop it, provinces can develop a framework, but it's a systematic, system-level approach that encompasses these principles that you see. And I worry when we put these things up, because these things are really easy to say and they're much more challenging to do. It extends person-centered care and advocates for environments that integrate trauma knowledge into daily care, extend the person-centered model to residents with traumatic histories, and uses neurobiologically informed intervention and supports frontline workers. Especially, but not only in the aftermath of COVID, of course, staff need help with their own COVID-19 experiences and with the things in their past that COVID-19 brought back up again. A big mission or a big goal of a trauma-informed care approach is to prevent re-traumatizing people. It sounds kind of maybe trite, but it's not. Many things that we do in long-term care homes and other settings are easily able to re-traumatize people. Just moving to a long-term care home can reignite things. We were working on trauma-informed things for residents before the pandemic, because we were working with some neurologists and trauma psychiatrists, because we believe that there's a subset of people with behavioral and psychological symptoms of dementia or responsive behaviors of dementia. There's a subset of them, especially in the very difficult group to figure out how to relieve them, that are probably expressing pretty aggressive PTSD. They're hard to distinguish, and the only way you can really get a good handle on it is to have knowledge about the resident, and we don't always have that, and knowledge from families. So it goes right back to taking proper histories, which are some areas, some homes are reluctant to do, and often there aren't the resources to, and there often aren't the mental health and well-being resources to support the development of these. The good news is there are really great resources out there. There's a group in Buffalo doing really good work, and there are other groups, especially in the US, because this has been in their accreditation criteria for some time. So nobody has to start from scratch. So all of these things I've just said are what led to what I want to talk about now, which is the next slide, which is the workforce resilience study. This is a study we did out of character for us, in that we were in the middle of a pandemic and we were in the middle of data collection, and we were talking to our stakeholders, and it was clear that the workforce was struggling. We had been out there interviewing care aides and nurses and allies and managers, and there wasn't any doubt, as if you needed to have it proven to you. And we wanted to do something, and we were asked if we could do something. And so what we did was develop the breathing study, which is a short study that really, if you're a researcher, you might think of it as capitalizing on low-hanging fruit. And I'll explain what I mean by that. Next slide. So this study was funded by Healthcare Excellence Canada through an agreement, a block grant they made to Alberta Health Services. And I think, from my perspective, it's one of the better investments any of us have made during the pandemic. Of course, there are lots of others. Next slide. So what is it? The intervention is coherent breathing. Now, we all breathe, so that makes it, to start, a little bit easier, but mental health professionals and yoga instructors and Pilates instructors and Zen Buddhists, I mean, this is not a new thing. There are all kinds of different breathing techniques out there. What we did is look for a technique that we had some familiarity with, that our trauma psychiatrist endorsed, that we thought was simple and straightforward, and that we could introduce into the workforce. So it's all the different breathing techniques are variations on this. It calms the nervous system. I won't go into all the mechanisms, by increasing parasympathetic, the calming nervous system activity, and decreasing the sympathetic fight and flight. We used polyvagal theory to guide us, but you can use there's lots of biological theories to guide this. If you've got your parasympathetic system cranked up, or at least in balance with the sympathetic, you get a slower heart rate, you get feelings of calm, and you get the release of good stress hormones. We taught the participants to take a deep breath and inhale to a count of 4, 5, or 6, whatever was comfortable, and expand the abdomen, and then slowly to exhale. So it's even in for, 1, 2, 3, 4, 5, out 2, 3, 4, 5, deep in the belly. And we asked them to start with 1 to 2 minutes a day, because it's not that easy. You might think it would be, but some people found it really challenging, and work up by 1 or 2 minutes a day till they hit 8 or 10 minutes. And we considered 5 days a week of practice a success. Next slide. If you like pictures, which I do, this is what it looks like. We did some prep and baseline data, a short little teaching of what is stress and why would breathing affect it, and what might happen if you were successful. 8 weeks of breathing, and then some final data collection and analysis. We had 2 groups. We had the idea, not that it was that, turns out not that brilliant a one, that if we divided our large group into 2, and one of them just breathed and the other one breathed using a biofeedback device, we speculated that group would do better, and I'll talk about how they didn't. And the study ran here in February to September of 22. For us, and I think for many jurisdictions, 2022 was actually the deadliest year for COVID deaths. So it was, you've lived it, that the pandemic wasn't over in 2022, and COVID-19 is not over now. So we're still living it. Next slide. We had 350 people from 30 homes who started. This was a convenient sample. They were care aides, managers. Well, they were only supposed to be care aides and nurses, but we had a group of managers from one organization ask if they could be part. So we said, of course. And we had 250 about that completed all the measures, and there were a lot of measures. Next slide. If you're interested in these things, on the right are the things we measured in the quantitative part, in the numerical part. Stress, anxiety, the kinds of things you would think that breathing might help if you could get a regular practice. Some we weren't sure of, we were speculating on, and then we adjusted in our statistical models for the things on the left that might affect the outcomes. So things like age and sex, of course, ethnicity, race, hours of housework, because we were looking at trying to find what we had, and we could find about how much general stress or workload they were under, their shift, the hours they worked, the kind of coping skills they had, and the kind of habits they might have had. Next slide. So this is the slide. Some of you may not like this slide, and I'll show you some other ways to look at it. It's part of a table that says that everything we measured, except for compassion satisfaction, and that's not surprising, improved from the time they started baseline to the post 8-week measure. So over an 8-week period, the people who could hang in all the way through got improvements in their self-reported measures of stress, anxiety and depression, resilience, insomnia, and compassion fatigue and burnout. Compassion fatigue is thought to lead to burnout, and we use the burnout measure in that particular scale rather than our own here, in part because it was shorter. We didn't expect so much improvement or improvement in so many things, but we got it, and we won't look a gift horse in the mouth. So this is not an RCT, a clinical randomized controlled trial. This was a simple pre-post over 8 weeks. There was no control group. So in the research world, it's considered a fairly weak design. And other things could have interfered over 8 weeks, and we don't know because we didn't control. But it was only 8 weeks. And you might say, well, COVID got so much better during that year that's probably why the scores improved. Maybe, but this was only 8 weeks. So we're fairly confident. We've run this by a lot of people. We've got it accepted with revisions. So we're pretty confident in the findings, but it's not an RCT. So you just know that. That's just a limitation. We're very excited about this. Next slide. There were no differences between the two groups, the biofeedback and the non-biofeedback. And we've seen this in a couple other studies where the technology didn't add anything. They weren't any worse, but they weren't any better. So that's good news, because it means that using it's even simpler than we thought it might be. Next slide. This is just another way to show you some of the data if you like pictures, which I do better than tables. So this just reflects what I just showed. And you can see that some groups got more improvement than others. The managers got really quite nice improvements, but everybody got improvements in most things that we looked at. So that's all this is just that line out of the table presented by group. So for example, there were about 6% fewer managers in the red zone, which suggests depression. Next slide. And this is a similar slide for compassion fatigue. Used to be called traumatic stress. There's some murkiness in the conceptualization of this professional quality of life scale. It's thought to lead to burnout. It's when your tank gets empty because you can't give anymore. That's a kind of a very superficial way to describe it. So you saw not as much improvement in the nurses, for example, but quite a really significant, not improvement, worsening in the managers. So their compassion fatigue got worse. That was very consistent with the interviews we were doing. Next slide. And that measures burnout scale. And again, there were improvements, by which I mean less burnout after the breathing study. Next slide. I'll just do a few slides about the process evaluation. So we were very worried that we couldn't recruit. And if we did recruit, there'd be this huge high attrition rate. And at the end, we wouldn't have any people left and we wouldn't be able to measure anything. So we went right to town on process evaluation, which is a qualitative evaluation of, is it working? What are the barriers? Why isn't it working? Why are they dropping out? How did it go? We had them do breathing journals. They did pretty good with those. Focus groups, questionnaires, little tiny short questionnaires. Next slide. These are just some pretty predictable reasons for not completing the study. We had some technical barriers and some perceptions that it took too much time. Mostly in the group, we used the biofeedback device with it. And then they had a lot of personal and other commitments. Next slide. Now, these are the things they talked about independent of the measures I showed you in the table. They talked about their sleep being better, feeling more relaxed, having better exchanges with residents and staff, just feeling better physically with less stress and anxiety, And they told us how they started using this technique in other situations other than just sitting quietly for 5 minutes, taking time out for yourself. Next slide. They also adapted it. They did all kinds of really creative adaptations during work, before work, after work, when I get home, prior to going to bed, after my shift, anything at work. If anything happened or anything with some of the residents, I used it. And a nurse or care aide who took the NCLEX, who had test anxiety, who thought that it had really helped her to do much better, and she passed the exam, so she considered that success. I think the reason they started using it in other ways happened at around 5 weeks. The process evaluation data we have that we haven't published yet, based on their diaries, suggests that at around 5 weeks, if they could hang in for 5 weeks, it took. And they started to feel better. And then they started thinking, well, if I could use it here, maybe I could use it there. Next slide. Unexpected results that they didn't expect to see. And the top one's really interesting. We knew ahead of time, like one of the reasons we did this study with staff at this time, not maybe the main one, was that we know you can't do this kind of intervention with residents with advancing and severe dementia. But we also know that we co-regulate, mammals co-regulate. I can co-regulate with a cat or a horse or my partner or with another staff member. So it's basically, if I'm calm, they're calm, and vice versa. I mean, not always, but this is physiological. This isn't mental. Being around a calm person helps you to regulate your own nervous system. So we knew that if staff were calm, if they could regulate themselves and feel better, that would help residents to some degree, at least, regulate, because it's a physiological response. It's not cognitive. So this care aide said, I try and calm myself down, and it helps them too. We saw several instances of this. I didn't expect to have an improvement. I imagine most of them didn't, to be truthful. But your stress levels will go down, and you'll be able to focus more on what you need to do. Next slide. This is a manager from a home that really went to town. We've talked about incorporating into our debriefing sessions. So when we have a code on site or any kind of aggression, we always debrief. And to get everybody's levels down, we start the debrief with a coherent breathing session. They're now doing breathing huddles. They've really incorporated into the way they work. For them, it's been a really positive thing. And another LPN says, I've been sharing it all the time. They talked a lot about sharing it with their kids, like trying to help their children be calm by getting themselves centered and calm. Next slide. So we're working now, we're in the later stages of, I have to make a confession, I'm skeptical about toolkits, because all by themselves, if you just put them out on the shelf, nothing much changes. But a toolkit is, I think of it as an essential but necessary but insufficient condition. But we're developing a self-directed toolkit. We're keeping it really simple. We're working with some care aides to refine what we did. Like, we developed some things from the study, then we're showing it to them and saying, does this work? Is this too much? Is this too little? Do you like the videos better than these things, etc.? And we're going to validate, is probably too strong a word. We're going to verify it and try it out a little bit with 3 or 4 care home staff. We're going to just say, we're going to work with the managers and the DOCs and say, here is this. Will you release it to all your staff, not just the care aides? We would like to come back in 4 weeks and do a couple of focus groups, ask you to push a 3 or 4 item survey out to your staff and talk to you, just to get a sense of, that's not so much, is it a good toolkit? We want to know that, but it's to figure out, if we can, not really figure out, get a few signals. Because some of the homes, the managers will get right in there and promote it. And we want to know how much pushing and nudging does the home or the manager or the educator need to do to get it going. And this work's also funded by HEC. So that's what facilitation means. Nothing, guidelines and dashboards and toolkits usually need some kind of nudging or help or facilitation or encouragement. So we want to see if we can get some signals about that, because that would help releasing it. And then the unanswered question is COVID-19. We did this in the middle of COVID-19. So that there was a huge need and pull in place. If that pull isn't as big now, will this be of as much interest? Because the kicker here is going to be, I think, to get people to, in good faith, give it a shot and try it for about 5 weeks, because it takes about that long to form the habit and feel the benefits. And next slide, I think I'm done. Yeah, so I hope this has been helpful. I wanted to go back and say, I think that the more we use data to find solutions, the better off we are. And the more we evaluate them, the better. But the solutions don't have to always be big, hairy things. They can be what I call low-hanging fruit. They can be simple solutions that, if implemented thoughtfully, and we do some evaluation, because you don't want to do things that don't work, because nobody's got enough time for that, I think we can use our data more than we use it generally as researchers when we're working with care homes and the frontline staff. So that's a plug for data-based interventions, and it's also a plug for neurobiologically informed interventions if we're thinking about trauma or traumatic stress. So thank you very much. I'm about where I thought I'd be, so we've got lots of time for questions, and thank you very much again for your patience.
Thank you so much, Dr. Estabrooks, and to your team for the presentation, and also really, as you mentioned, what you call the low-hanging fruit. I think this is such a wonderful example of perhaps a very practical and I don't want to use the word simple, but relatively straightforward intervention that seems to show lots of positive impact on supporting the workforce. So yes, we do have lots of questions that have already come in, and I am going to encourage people to continue to send in their questions, and we'll manage those into the chat box. Maybe I'll start, but I have a few, but I won't ask you all of them. My first question, then we'll go to some of the audience, is you mentioned a little bit there was some impact or results that might have surprised even the participants. From your perspective, what was most surprising?
Well, I was, just as a skeptical researcher, surprised that they would do it. Enough of them would do it long enough to feel the effect. And I was really surprised that we could identify that threshold place around 5 weeks. I did not expect care homes, not all of them, we had 30 care homes, but maybe a half a dozen really took it up. And I thought, oh, this might be the way to release this at the home level or the unit level, so that, because if the manager was cynical and skeptical, or had been there 2 weeks, because there was an awful lot of turnover, it was much harder to get the care aides involved.
So yeah, that's lots of interest in participation and continued participation, which is great. So I think the first question from the audience, I think it pertains to some of those first slides you showed about some of the data and the link between a positive work environment and health of staff. Did you encounter any barriers for respondents who may be hesitant to participate due to stigma or concerns for their license? And if so, how did you account for this? And so I think it was specific to that first part of your presentation, but maybe you could speak to that just more generally.
That never came up, and that we've been collecting data from care aides a long time, and we occasionally have a care aide in the room or on the call that doesn't want to be there or is scared of repercussions. And sometimes we just sit with them for 20 minutes and they go back to work because their manager will get mad at them because they didn't do what they were supposed to. That doesn't happen very often. That's not to say those aren't there, but we have never encountered that issue around licensing or work. And some of the questions we ask people are really sensitive, but I also shield the data. There are data I do not show at anything but a highly aggregated level to the stakeholders. And I'm very careful. We suppress cells if there aren't that many people in the cell so that they can't be identified, because we have a lot of demographic information that makes it identifiable if you don't do that. And we work with the people out in the system to say, this is how these data should be used. I had one instance about 10 years ago where a region had just a particular set of people, and the people higher up in the system got a hold of the reports we give back to the facilities, and they were used punitively, and we were 18 months repairing things, and it's all better now and fixed. But that's not, that was really rare. I've been doing research for 30 years, and that's the only time that's ever occurred. Most of the stakeholders we work with, what they want to know, like the managers, and is how do we use this data? What does this data mean? Et cetera, et cetera.
Okay, thank you. So I think related to the start of your presentation is when you talked about favorable work environments. So just a few questions around that. Yeah, how would you define and measure that? Are you looking at things like organizational policy, staffing ratios, the culture, complaints, absenteeism? Like what goes into a favorable work environment?
So there are a lot of ways you can measure it. We include some of those things in some of the work we do, but the core way we assess work environment is a unit level measure. It can be used at the facility level, but doesn't perform as well. Is we have a tool, we call it the Alberta Context Tool, because it's spelled a nice short acronym, is really why we did that. And it measures 10 things. And to get the red and green, we do some clustering and spinning, and we pull the data apart into the homes that we can cluster them into 5 categories or 12, but we cluster them into 2 because that's what the manager said was most helpful. What's in that tool are measures of leadership, not executive leadership, of the person you report to. So because most care aides report to an LPN or nurse, it's measurement of that level of leadership, and sometimes the manager. Culture, do you get data and then have a process to use the data and to get feedback on what you're doing, essentially? Some resource questions, some questions about how much buffer they have in their system. We call it organizational slack. What their perceptions of their time, their space, and their staffing are. How much informal communication there is. How much they, in care aides in particular, engage in places like meetings where decisions about residents are made. Not very much, it turns out, in almost over 15 years. And I think that's the most of them. So it's a composite measure that came from a model we work with, an implementation model from England that says if you have a good work environment and you have good facilitation, coaching, education, and you have good enough evidence, that you will get better improvement results and better implementation results. So we've worked a lot on the context of the environment bubble.
No, that's super helpful. And I assume that tool, the Alberta Context Tool, is something that is publicly available. People can find out more about that. Great. I guess related to that, and it's just a follow-up. I know you'd mentioned modifiable, like that's what, do you have any insights? I mean, I think it's the holy grail of some of the work that a lot of our organizations are trying to tackle in quality improvement and long-term care. Anything that's easily modifiable that supports easily, maybe that's
Yeah, it's a loaded question. So we try, we're not always successful, but we try very hard to only measure things that could be modified and that somebody might care about for some reason and might use the findings for. It sounds kind of obvious, but like researchers can get off and measure all kinds of things that aren't modifiable or are so hard. So is burnout modifiable? It's tough because it's a chronic state, but yes, it's modifiable. What is the low-hanging fruit around interventions? For me, the lowest hanging fruit in long-term care, I mean, I know that adequate staffing and resources is a necessary condition. And it's hard to do much when you're up to your patoot in alligators. I know that. I know if you're using 60% agency staff or your staff are working short all the time, it's tough. If we just set that over here for a minute, I think the work environment is the single most important modifiable thing. And inside of that, what would I pick to start with? We have a teamwork measure inside it. I would start there, and I would do that in concert with, this isn't leadership to be the great leader of the world or anything. This is frontline leadership to support staff to do their work and support change. So it's not it's not like sending people off to get Myers-Briggs done. It's pretty practical. And the reason I say teamwork is that the social, that's we call it social capital, is that it comes up in a lot, quite positive in a lot of our research models, our statistical models. But when you go out and talk to staff, we did some focus groups with care aides about work environment. We asked them what was most important. And they said, well, it's teamwork, and then it's teamwork. They said, we'd rather work with half the staff if it's a good team than all the staff if it's a bad team. So teamwork isn't easy always to improve, but it's a concrete thing. Where it gets hard is that most nursing homes are working with really racially diverse care aides or PSWs from lots of countries and conditions. Mostly women, tend to be a bit older. They're at the bottom of a really rigid hierarchy often. They're not getting enough education to care for the really complex people that they have in their charge. So it's not easy to look at work environment and to look at teamwork, but it's possible. And what makes up teamwork? It starts with the bread and butter stuff. About how do we work together well? How do we be respectful of each other? How much autonomy do we have? How much ability to participate in how we do our work, et cetera, et cetera. We don't study generally issues of race and ethnicity, but we've been doing some qualitative work recently and asking some questions that tell me we have really significant levels of at least microaggressions in the workplace, and they're not all coming from other staff. The care aides and PSWs are dealing with a lot of aggressive racial remarks from residents, and they're in a quandary because they know the residents have a dementia, so they know they're not culpable, but that doesn't mean it doesn't still affect them. So I think there's some things around that we could do that would really help. But I've had nurses, and I'm a nurse, been a nurse for 40 years, tell me that care aides don't make decisions, and I just don't know where they get that. Not a lot of nurses, but sometimes I'll run into one, and they don't observe, and they don't, well, I don't know who we all think is bringing the information forward to the nurses and the manager and the LPNs. So I think we have a lot of work to do with all levels of staff. But the care aides are such large numbers and do so much of the direct care that, anyway, that's where I would start. I would start with teamwork and leadership. There's other things I would do too. And I know that, you can't, I was taught as a nurse that I was doing psychosocial unit or something. And I was taught that I couldn't give psychological care to a corpse. So I better tend to the ABCs first. So there's some ABC work we have to do in long-term care, but we can still do some of the other things, I think, along with it. And there's some really creative stuff going on in some of the homes in this country. You know that at HEC better than most.
I know it's a lot of options, but I think the key message there is teamwork is one of the ones that you could focus on. And just related, perhaps somewhat related, when you talked about initiatives, interventions, so you mentioned trauma-informed care. Have you, what types of initiatives or interventions in long-term care have you heard or seen or know about that are actually supporting trauma experienced, I think, by team members? This question is specifically by, I guess, the staff in long-term care. Have you?
I think in this country, specific to older adults who lived through the Holocaust, there's no doubt that Baycrest has some of the most advanced practices, and they've had to. There is no doubt in my mind that some of the homes that have large groups of veterans have dealt with this, even if they don't call it trauma-informed care. Most of the research in trauma-informed care, however, has been done on Holocaust survivors and veterans. Those are really important groups, but there's not much on first responders, and there's nothing almost in long-term care. What I'll call, it's not regular, but I'll call regular trauma, the things that happen to you in your life, near-death experiences, single event traumatic things like rape as an adult, protracted childhood trauma. So I think we have so much work to do, but places that have concentrations of people where there's been a lot of work and they've had to adapt have some of the best practices. In Alberta, I've seen some of the most informed staff in units or facilities that are specializing in mental health. They're getting taught about trauma. It's a whole different world in some of those units than it is out on the vast majority of units. So that's what I know. I know that acute care has done more, especially in pediatrics. That doesn't mean we've done enough. Different regions in the country are doing some things, but in terms of what's spreading down into staff levels where it's being embodied, I think probably there are relatively few, and they are concentrated in those kinds of places.
Thank you. If we have time for maybe 2 more quick questions. I don't know if they're quick, but did your study attempt to identify organizational root causes of stress, anxiety, burnout amongst your participants? Did you control for organizational culture? I think that's the breathing study.
No, we did not. I mean, I can tell you the same things everybody knows about what some of the causes of the stress are, but during the pandemic, the causes were additional and unique. And the most profound one I heard from staff when we were doing interviews was the extreme isolation, and having to watch people not being able to give the care you knew you wanted and needed to, watching people die alone, having to deal with families. And there was all kinds of other things that went on during the pandemic in terms of fear and anxiety, and not knowing how we could protect ourselves in the beginning. But that isolation from the really severe isolation practices we put in place, I think is one of the big lessons coming out of the pandemic that we would want, I hope we don't do over again. We didn't do that to children. Just saying. I mean, I understand we were all scared and reactions were swift and harsh, and maybe too harsh, and sometimes they lasted we have incidences of patients, or residents rather, being in their rooms in essentially solitary confinement for 3 or 4 months on end. And you know what happens to an older, frail person with 2 days in bed, let alone 3 months. So that's, I think, during the pandemic was one of the hardest things I heard, and the rapidity with which people were dying. You know, they couldn't grieve, they couldn't process, it was the interviews we did in 2021. I never want to be part of anything like that again. It was so heartbreaking. It was the hardest stuff I've ever heard.
I can only imagine. So just to end, I think the last quick answer maybe, and we did get lots of comments about workload and interest in Trek, looking at how organizations and I guess long-term care homes could change this. So I'm not going to ask you to answer that question, but more of a comment. And the last one was, what role do you think there is for physical ergonomic interventions in reducing the workload burden for healthcare workers? Should this be a priority?
I think there's some. I don't think it's not enough to change things, but if you think about health, physical health in particular, it's obvious we need to maximize that area. And every time I get a chance, I say, you know, if we would spend the money on compliant flooring, it'd be the most important thing we could do to prevent injury falls, but it's expensive and we don't think that's important to spend that money at kind of higher levels in the system. But yes, absolutely, it's important. It wouldn't be the first thing I went to, but it would be if I was trying to say, what are the 10 things we have to do? I might put it on the list and say, let's work on all these. Let's do what the priorities first, but let's not forget, you can't forget that. Just like you can't forget recreational therapy and recreational therapy assistance. I mean, that's one of the most egregious things I think I've heard across the country is how we thin that particular part of the workforce, because it's so important for social things and relationships and meaning and enjoying your life a little bit.
Absolutely. So I think that's all the time we have for the questions. And if you have a peek at the chat, there's lots of really positive comments and just acknowledgement, even of you talking about the isolation that was experienced by probably both staff and residents in the long-term care and in the pandemic particularly. So I just want to say thank you so much to our audience for the excellent and engaging discussion and questions that have come in, and also, of course, to you, Dr. Estabrooks, for the wonderful presentation and all the work that your team has done to really give us some tangible things that can be done to support wellness. So we really appreciate your feedback to let us know if you found this session helpful to you. So you'll see on the screen, if you don't already, just a few poll questions. We'd love if you could just answer those. And the question on gender, just a reminder, that's an optional question that, I mean, all these questions are optional. That one specifically, our funder, Health Canada, requests that you answer that question. Our next webinar will be October 18th and from noon to 1 Eastern time. And that's going to be feature a discussion with the CSA group regarding the recently released standard for long-term care home operations and IPAC infection prevention and control. So once again, I want to thank all of you and Dr. Estabrooks for the presentation today. And that's it. We'll see you soon. Have a great day.